chapter deals with the blood. We're going to look at the anatomy of the various types of blood cells, the physiology of blood, so that you can learn what is normal, what is abnormal, how to prevent blood disorders, and how to treat different. Blood is transport mechanism in the body, transport to various things such as oxygen and nutrients and waste products. It helps to regulate different functions and also helps for in terms of transport lines. It helps to deliver those oxygen and nutrients which are necessary for all cells for survival. It's also transporting waste products, either carbon dioxide as a waste product to the lungs or other waste products to the kidneys for you to eliminate them. And then it's also helping to transport things like hormones from the endocrine gland to the target cell or the target organ, depending on which one you're talking. For regulation, it's helping to regulate body temperature. It's able to absorb heat, distribute that heat to different areas of the body. It helps to maintain the proper normal pH. There are different buffers, etc., that we'll learn about that are used. But the pH of the blood is going to be very, very closely monitored and maintained. You don't want too high or too low, or you can certainly end up with catastrophic results. It's also, the blood's involved with maintaining adequate volume in the circulatory system. You don't want the volume of blood to increase too much or decrease by too much, so it can make adjustments there. In terms of protection, it helps to prevent blood loss. We'll go through the steps. If there is an injury, of the steps involved for clot formation. You don't want clots within the circulatory system in terms of impeding blood flow, but you do want clots to form when there's been a break or a tear to prevent blood loss. And then it also plays a role with preventing infection. There are a lot of components within the blood that are going to play a role with preventing infection, things like antibodies, white blood cells. So what's the composition of the blood? Most time you might just look at it, it's just red, it's just blood. Well, number one, this may sound strange, but it is considered as a tissue. It is a connective tissue. And you might be, well, it's fluid. That's okay. It's still a tissue. The matrix, which, remember, with connective tissue, you will have the cells and then you have the matrix, that extracellular material. For blood, the matrix is a non-living fluid. It's what we call the plasma. The cells are what we call the formed elements. So if you look at blood, you can divide it into those two categories. The cells are going to be suspended within that plasma. With the formed elements, you're going to have three components. You will have the erythrocytes, which is just a fancy way of saying red blood cells. You have the leukocytes, which are white blood cells. And then you have if you took a sample of blood and you were to spin it, you would end up with three layers. On the bottom, roughly about 45% of the overall blood volume is where the erythrocytes, or those red blood cells, are going to be. A hematocrit is the percent of blood volume that is red blood cells. Normal value for females and males, it's going to be a little bit different. Males, it's roughly on average about 47%, but notice plus or minus 5%. Females, about 42%. Once again, plus or minus 5%. So it's a little bit lower in females than males. The white blood cells and the platelets together are going to be in this layer between the erythrocytes on the bottom and the top layer, which is where the plasma is. And that's what we call the buffy coat. It's less than 1% of the total volume. But that's where the white blood cells and the platelets are going to be. The plasma, which comprises about 45% of the total blood volume, is going to be on the top layer. So this is just showing if you draw blood from an individual and then you centrifuge it, this separates out by density. As you can see, the erythrocytes are more dense, so that's why they're going to be on the bottom. That whitish, kind of looks like a line in the middle, is going to be the buffy coat. That's where the leukocytes and platelets are, and then the plasma is on top. Because it does not have the erythrocytes in it, it has kind of a straw yellowish type color to it. In terms of the physical characteristics of blood, it's usually opaque, it's sticky, it's often described as having a metallic taste. I don't want to know how people found that out, but we'll just go with it. The color is going to be dependent upon the oxygen content. If it has a high oxygen content, then it's a very bright scarlet red. If there's low oxygen, then it actually looks like a dark red. Because it's traveling through the veins, you might say, well, my veins look more bluish purple. Part of it has to do with the layers of the walls of the blood vessels, but it's actually a darker red. The pH, as I mentioned earlier, is going to be very closely regulated. It is going to be in the range of 7.35 to 7.45. Overall, how much of your weight is blood? About 8%. In terms of the volume, males about 5 to 6 liters, females a little bit less, 4 to 5 liters. The blood plasma, like I say, it's kind of yellowish, straw colored fluid. It's composed 90% of water. It has a lot of solutes that will be dissolved in it. Nutrients, gases, your hormones are going to be in there, waste products. There are proteins. The most abundant of the solutes will be your plasma proteins. A lot of these proteins will remain in the blood. They're not going to be taken up by cells. Proteins are usually produced in the liver. Albumin is going to make up about 60% of the plasma proteins. It's going to help carry other molecules. It's going to play a role as a buffer, which is going to help keep that pH stable. And it's going to play a So this table shows the composition of the plasma, what the components are, what the importance, or what the description of it is. And this is continued over here, continuing with the hormones, the gases. For the formed elements, like I said, this is the cells. Excuse me. You have your red blood cells, your white blood cells, and your platelets. Only the white blood cells are what we call complete cells. And why is this? Well, your red blood cells, the mature red blood cell does not have a nucleus. And it does not have any other organelles in it. So there's no mitochondria or anything like that. The platelets are simply fragments of cells. Most of your formed elements are only going to survive for a few days. They certainly do not survive a lifetime in your blood, so you're constantly making more. Most of them are going to originate in the bone marrow. So this upper picture shows a scanning electron micrograph of blood. They have added coloration to it, so the leukocytes are not necessarily those yellowish colors there. But it gives you an indication of the size. So the platelets are much smaller than the red blood cells. And then on the photograph on the bottom picture, that is of a human blood smear. The red blood cells, the shape of them, kind of almost like donut shape. And so usually the middle looks a little bit lighter than the edges. You can see they look red. There is no nucleus in them. Now these have been stained so that the nucleus does pick up this purplish dye. So those larger cells that you see with the purple in the middle, the purple would be the nucleus. that right away tells you it's not a red blood cell. They are actually white blood cells. You notice they have different names. Erythrocyte, monocyte, lymphocyte, eosinophil, neutrophil. We'll talk about those in a moment. Those are all specific types of white blood cells. And then those little teeny tiny kind of purplish pink dots, those are the platelets. Much smaller than the other two cells because, as I said, they're only cell fragments. So we'll start with the erythrocytes, the red blood cells first. They're very small. They're about 7.5 to 8 micrometers in size. Their purpose is to help transport gas. They do not have a nucleus. They do not have organelles. They are biconcave that look like a disc. They are filled with hemoglobin. So the gas will actually bind to the hemoglobin. The red blood cell diameter is larger than some capillaries. So just through the capillaries, which are a type of blood vessel, they're going to have to go single file through and kind of squeeze through some of them. They may contain within them some additional proteins that help such a spectrum that gives flexibility shape a little bit to fit through the real smallest of the capillaries, real tiny ones. This certainly shows how structure determines function. The biconcave shape does give a large surface area, so it allows for the gas exchange to occur. Hemoglobin makes up about 97% of that cell volume, not counting the water. They don't have mitochondria, so they don't consume oxygen that they transport. So they're going to transport it. So this shows a view of the erythrocyte. So like I say, the whole purpose is to bind gas and transport it throughout the body. Normal values for hemoglobin in males is about 13 to 18 grams per 100 mils, and females 12 to 16 grams per 100 mils. The hemoglobin consists of a red pigment, which is called heme, and is bound to a protein called globulin. The globulin has 4 different chains to it. The heme pigment is what gives it the red color, and then each of the hemes will bind to one form, so they combine 4 oxygens per hemoglobin. That shows the structure. So if each hemoglobin molecule can transport 4 oxygen molecules, and each red blood cell contains about 250 million hemoglobin molecules, that means you can carry an awful lot of oxygen. Now, when you pick up oxygen, when that blood is going through the lungs, you've got that red blood cell, we have what we call oxygen loading occurring. And what happens here, what that just means, oxygen loading is with the oxygen molecule, it will bind to the hemoglobin that's inside the red blood cell. It's kind of like you're loading up that cell with its cargo of oxygen. And it produces what we call oxyhemoglobin. So that just means that you have oxygen attached to the hemoglobin. It's going to look this very bright red. In all the other tissues in the body, so when it leaves the lungs, it's going to be transported to everywhere else in the body. In all the other tissues, you have oxygen unloading. It's kind of like you got to your destination, you got to unload the luggage. So you are going to have that oxygen be released. It's going to unbind from the hemoglobin, and it produces what is called deoxyhemoglobin. Deoxy, D means without, oxy means oxygen, so it means you took the oxygen off of it. It now looks a dark red in color. You also at the same time have carbon dioxide loading in the tissues. So not all of the carbon dioxide, but about 20% of it, when the oxygen is unloaded, the carbon dioxide loads, producing the carbonaminohemoglobin. Carbon dioxide is the waste product that is produced during metabolism in the cell. And so excess amount of CO2, carbon dioxide, can actually be fatal. And so it's a waste product, you must get rid of it. So if you want to think of the hemoglobin kind of like a taxi cab, they left the lungs loaded up with the oxygen, gets to the tissue, and it unloads that oxygen, and now it picks up the next passenger, which would be the carbon dioxide. So back to the lungs and get rid of that carbon dioxide unloaded there. In terms of production of your erythrocytes, that is hemopoiesis, which is the formation of it. It occurs in the red bone marrow. Where is the red bone marrow going to be found? In adults, it's mostly in the axial skeleton, in like the pelvic girdle, your hips, on the proximal epiphysis of the humerus of the femur. Stem cells are going to give rise to all of your formed elements, and then hormones and growth factors are going to help direct where that stem cell, which pathway it's going to go down. Does it form platelets? Does it form the red blood cell? Where does it go? Once it's determined which pathway you're going to go, that's it. You cannot change. So the stages of it are of erythropoiesis, this formation of the red blood cells. The process is going to be about 15 days. So you're going to start at the beginning with a stem cell, the hematopoietic stem cell, and it's going to then transform into a myeloid stem cell, which then is going to transform into a proerythroblast. That's going to divide many, many times and eventually transform into what is known as a basophilic erythroblast. Then is going to form the polychromatic erythroblasts. And then you have your orthochromatic erythroblasts. Some of these, when you stain them, they look different colors depending upon how much hemoglobin has now been placed in there, how many other proteins are in there. During the 6th stage, the orthochromatic erythroblast stage, there's a lot of hemoglobin. At this point, the cell loses its organelles and the nucleus is going to break down. And that's what causes that concave type shape. From there, you move to the reticulocytes, you still have a few ribosomes there, and then the last stage is the mature erythrocyte, and the final ribosomes are going to degrade, and once again, you've already lost the nucleus. So this is showing the various stages until finally you have that mature erythrocyte. If you do not have enough red blood cells being produced, it can lead to tissue hypoxia. You don't have enough red blood cells, you're not carrying enough oxygen, that tissue is now suffering. If you have too many red blood cells, it increases the blood viscosity. The kind of viscosity refers to like the thickness and how well it's going to flow. And it's like it's more sticky, and that's going to certainly be a problem. So it's got to be very closely regulated. There are over 2 million red blood cells that are being made per second. And you have to also control not only how many red blood cells you're making at one time, but red blood cells, as I said a bit ago, they don't last forever. And so there's got to be this balance between how many are you making versus old ones that are dying off and need to be destroyed. And that a lot of that balance is going to involve hormones as well as dietary. The hormonal control, erythropoietin or EPO, is the hormone that does help stimulate that formation of the red blood cells. So you always have some of that hormone in the blood, so you always have a residual process or base rate where you're always making some red blood cells. The question is, do you increase that greatly or not? This hormone is made, as you know, in the kidneys. Some are made in the liver, and it's going to be released partly in response to hypoxia. If low levels of oxygen are sensed, then you're going to want to increase the amount so that you can increase the amount of red blood cells so you can get more oxygen to the cells. What are the causes of hypoxia? Well, decreased number of red blood cells. Maybe more of them have been destroyed lately, or maybe you're hemorrhaging and you're losing them. It's no longer in the bloodstream. Insufficient hemoglobin per red blood cell, such as with an iron deficiency. Reduced availability of oxygen can lead to hypoxia. Maybe you have a lung disorder, maybe you have pneumonia, or if you're at high altitude. These things would all could cause hypoxia, which in turn are going to increase the secretion of the hormone to then stimulate more increased production of the red blood cells. If you increase the amount of red blood cells, like I say, then that means you have more cells. They can buy more oxygen, and then you are able to increase the amount of oxygen being delivered to the tissues. If you have too many erythrocytes or high oxygen levels, the blood's going to start to inhibit the EPO production. We don't need as many red blood cells. Slow it up. Does it stop it completely? No. Just slow it down a bit. Testosterone does enhance the EPO production, so that's why red blood counts are higher in males than in females. So this is showing, as you've seen before, this trying to maintain the homeostasis. And the amount of red blood cells is going to be related to what is the blood oxygen levels. Now, in terms of some of our clinical manifestations, some athletes will abuse artificial EPOs to try to increase their hematocrit. Why? Because this increases the amount of red blood cells, which means more oxygen, which means increased stamina, which means increased performance. That might sound good, but there are some dangerous consequences to this. You can increase that hematocrit way up, but oftentimes what happens, you're going to be concentrating that blood even more. The blood's going to become very viscous and, like I say, sticky, almost like a sludge, where it's not flowing well. You want it to be flowing very easily through the blood vessels, and you mess up and change these percentages, and if there's too many red blood cells, yeah, it can carry more oxygen, but that's not going to do you any good if it can't flow through the blood vessels. And it's not going to do you any good if then you start forming clots and you end up with a stroke or you end up with heart failure. In terms of dietary requirements, you need to have amino acids, lipids, carbohydrates. You need to have iron. That's probably one of the main things that causes problems for people, is whether they're receiving enough iron in their diet. And then vitamin B12 and folic acid. The lifespan of erythrocytes is about 120 days. They can't divide, they can't grow. It's dependent on the original stem cells. So what happens as a red blood cell starts reaching that 100-day mark, the old ones, they become very fragile. The hemoglobin starts to degenerate. They can get trapped in some of your smaller capillaries, especially in the spleen. And then what will happen is macrophages are going to engulf them, break them down. When a red blood cell is broken down, the heme, the iron, and the globulin are all separated. The iron combined and is stored, basically is reused. The cells in your body is great at reusing and recycling things. The heme is going to be broken down to a yellow pigment called bilirubin. The liver is going to secrete the bilirubin with the bile into the intestines. It's going to be broken down, and it leaves your body as a waste product. Globulin is going to be broken down into amino acids that then can. So that initial red blood cell matures, enters into the bloodstream, will last for about 100, 120 days, and then it's broken down. Most of your erythrocyte disorders are classified either as anemia or polycythemia. Anemia is when blood has abnormal, low oxygen carrying capacity. It's not necessarily a sign of a disease itself, but it's a problem that you have to deal with. The symptoms are often tiredness, light colored skin, chills. There are different causes for anemia. It could be due to blood loss, there's not enough red blood cells being produced, or too many destroyed. So if it's due to blood loss, this could be hemorrhagic anemia. It's rapid blood loss. Maybe you've had a severe wound. You need to replace that blood loss. Chronic hemorrhagic anemia is you have a slight blood loss, but it's persistent. So it's constantly happening. It's not all at once. It's a small amount, maybe through hemorrhoids, maybe through a bleeding ulcer. Here, the primary problem has to be treated, because if you don't treat the initial problem, you're still going to continue to have that blood loss. So you have to stop the blood loss. And iron deficiency anemia is not having enough red blood cells being produced. So either you have low iron intake, or you may be taking in iron, but you're having problems absorbing it. The red blood cells tend to be much smaller, paler in color. They can't synthesize hemoglobin because there's not enough iron there. So what would be the treatment? Take an iron supplement. Pernicious anemia is an autoimmune disease. It destroys part of the stomach mucosa that's producing this intrinsic factor that's needed to absorb vitamin B12. You need vitamin B12 to help the red blood cells to divide. So in the process of them going through that maturation process, the red blood cells are going to enlarge, but they don't divide. So then you end up with a very large cell. So the treatment is to take B12, either as injections or as a nasal gel. Usually you start off with injections or the nasal gel treatments once a day for about a week, and then once a week for about 4 weeks, and then you move on to about once a month. This can also be caused by low dietary intake of vitamin B12, which we're seeing can often be a problem. May not be receiving enough B12. Renal anemia is caused because you have a lack of the EPO, which, remember, that is a hormone that's involved with making or stimulating the red blood cell production. Sometimes this is also associated with a combination of various renal or kidney diseases. Treatment: take the synthetic EPO. Aplastic anemia is when you have destruction or inhibition of the red bone marrow. This can be caused by sometimes interactions from drugs, chemicals, radiation, viruses. And you may not be able to determine what the exact cause is. All the formed elements, cell lines, are going to be affected. So you're going to not only have anemia, but you're going to have issues with blood clotting, and you're also going to have issues with your immune system. The treatment, short term, is with transfusions. Long term is looking at transplanted stem cells. If you have too many red blood cells being destroyed, what's happening is the red blood cells start to lyse, break down prematurely. So now you have too many of them being destroyed. It can be caused by infections. Sometimes it can be triggered by a transfusion where you received incompatible type of blood. Could be due to hemoglobin abnormalities. That may be due to a genetic disorder, such as sickle cell. Thalassemia, it's more common in people. It's genetic from a Mediterranean ancestry. One of the globulin chains is either faulty or it's absent. So the red blood cells tend to be very thin. They're deficient in hemoglobin. Sometimes individuals have this, the severity may be very mild, others it can be very severe. So some individuals in a severe case may need to have monthly blood transfusion. Sickle cell anemia, what has happened is there has been a mutation with the production of the hemoglobin. The hemoglobin, the globulin, is a protein chain that has 146 amino acids. This is an example where a mutation occurs. Location is critical. In this case, of the 146, only one amino acid is changed, but it's in a critical place. And what happens is the red blood cell becomes crescent shaped when oxygen levels are low instead of being round. Structure determines function. So you get that crescent shape, that misshapen. It's not nice and round. It's going to have problems going through the blood vessels, and it starts. Number one, they can rupture easily. They can block up the blood vessels. So now you're decreasing even more so the amount of oxygen that can be delivered to the uh, various tissues. It can also be very painful. Sickle cell anemia is prevalent in people of African descent. I say it is genetic. It is what we call a recessive trait. Now, the only way you're going to have sickle cell anemia is if you have two of these recessive traits. So you get, for every gene, you get one from mom and one from dad. So you would have had to have received one from each of your parents. There's an interesting thing genetically with sickle cell anemia is that they have found that people with sickle cell do not contract malaria. It's like they have this natural protection against it. Now, malaria kills about 1 million people a year. It's one of the reasons why they have been trying to look for some type of a vaccine against it. If you have two copies of the sickle cell gene, you will have sickle cell anemia. You're going to be protected against malaria, but you're going to have sickle cell anemia. Now, the interesting thing is that if you have one copy of the sickle cell gene and then one normal gene, will you have sickle cell anemia? No, you will not. But will you still have protection against malaria? Yes, you will. So in that case, there'll be a benefit to having just one gene, but you don't want both. Because if you have both, you have sickle cell anemia. If you just have one sickle cell gene and one normal gene, you will not have sickle cell anemia, but you will have protection against malaria. But you could pass that sickle cell gene to your offspring. It's just kind of an interesting way how that is developed genetically. Treatment for sickle cell anemia in acute cases, you can have blood transfusions. If you try to keep high levels of oxygen, you do not get the formation of that sickle cell. Tried looking at stem cell transplants and gene therapy, so they're looking at several. This shows the difference in the shape, the normal erythrocyte versus the sickle cell. Polycythemia is abnormal excess of red blood cells. Like I said, that's going to increase that viscosity and it's going to get real sluggish. And you have the potential for blood clots and decreased blood flow. What leads to this? Well, possibly cancer in the bone marrow can lead to excess red blood cells. Your hematocrit may go way high. Part of what you may need to do to help treat this is periodically, um, at a higher rate than what would be considered normal, is to have blood drawn to get that blood volume down, get that thickness of the consistency of it down. Another reason can be caused by low oxygen levels. So remember, low oxygen levels is a stimulus to increase the EPO production, which is increasing the red blood cell. Why would you have low oxygen levels? One example of this is if you're living at a higher altitude. The higher up you go, the less oxygen there is. Some people will use this as a training for various athletic sports. When I lived in the Albuquerque area, Albuquerque is a mile high. A lot of people don't realize it's as high in altitude as Denver is, but it is high. But our weather is a lot warmer than Denver and a lot more sunny days, so there actually are several athletes, runners, bicyclists, etc., that will come and live and train in Albuquerque. Because of the higher elevation, they're producing more red blood cells. Red blood cells, as you know by now, bind the oxygen, and that can increase your stamina. So some of these professional athletes will train at a higher elevation, such as in Albuquerque, but then when they compete, they go down to sea level. Well, they have a higher percentage of red blood cells, which means they can load higher amounts of oxygen than somebody who's been training at sea level. And so that means that increases their stamina. Blood doping, this one athletes will remove, store, and then reinfuse red blood cells before an event, trying to increase those oxygen. The leukocytes, these are the white blood cells. These are complete cells, so they have the nucleus, they have the organelles. Remember, they only make up about less than 1% of the total blood volume. The numbers of them will vary. Their main role is protection, so they're going to help fight against disease. They can leave the capillaries. They move through spaces, and sometimes they will move due to what we call positive chemotaxis. Chemotaxis is when a chemical is released and it attracts something or it repels it. So positive chemotaxis is where the white blood cell will be attracted to certain chemicals. If it was a negative chemotaxis, it would be repelled and want to move the opposite way from it. So we know what the normal white blood count would be. Any increase in that would be normal response to infection. So we know about how many cells we should have per microliter, and then know that anything above that is going to or should trigger in you kind of a red flag of, ooh, does this patient have an infection? There are 5 different types of leukocytes, and we classify them into 2 categories, the granulocytes and the agranulocytes. And the difference between these two, as the name implies, is what do they look like? When you stain them, the granulocytes look like they have in the cytoplasm all these little granules. Kind of looks like somebody dumped sand in it. Agranulocytes, A means without, so that means they don't look that way. They don't look like they have sand dumped in them. In terms of the abundance of them, the order of which of the types, the 5 different types of white blood cells and their normal concentrations of them. Some people use the phrase, never let monkeys eat bananas. And that's going to give you the phrase for never let monkeys eat bananas, the neutrophils, lymphocytes, monocytes, eosinophils, and basophils. So when you look at the formed elements on the far left, you've got your platelets, your erythrocytes, your leukocytes, and since that's not drawn to scale. But if we look at just the leukocytes, which are the white blood cells, if you do a differential count of the white blood cells, meaning you're going to look and try to distinguish between the 5 different types of them. So you're not just getting a total count. You're going to look at these 5 different types. You can see how it breaks down. The top 3 are the granulocytes, and on the bottom 2 you see the agranulocytes. The granulocytes are the neutrophils, eosinophils, and basophils. They are going to be larger than the red blood cells. They're going to be, in terms of the lifespan, be shorter lifespan than the red blood cells. They do contain nucleus because they are a complete cell. The cells tend to be kind of, they're referred to as lobed. They're not the circular nucleus that you're probably familiar with. They're granulocytes, which means that you will see when you do a stain, we use what's called a right stain. The granules will stain a particular color. All of these can carry out phagocytosis to some more than others. So if we look at those, the neutrophils are the most numerous of those white blood cells. They do account for about 50 to 70% of the white blood cells. They are large. When you stain them, you can use acid and basic dyes to stain. They are often or sometimes called polymorphonuclear leukocytes or PMNs because the nucleus is lobular. It can have anywhere between 3 and 6 lobes to it. They do carry out phagocytosis. They often will poke holes in the membranes of bacteria that they engulf. So they are very good at helping to protect you against bacterial infections. If you have a high number of these or abnormally high concentration of these, it would be indicative of a bacterial infection. So if you look at this under A, the neutrophil, you can see that it has those multi-lobes. The granules in them some are reddish color, some of them are kind of a bluish color, so you have both colors of those granules in them. As you can see here more close up. Eosinophils. This accounts for about 2 to 4% of all the leukocytes. The nucleus is going to have 2 lobes with a little band typically that connects them. They are often described as looking kind of like earmuffs. The granules are going to stain red. Eosinophils are going to be seen when you have like a parasitic infection. They also play a role dealing with allergies and asthma. So as you can see here, the eosinophil is that bilobed, meaning it has 2 lobes with that connecting strand, if you will, but then the granules in the back look red. Remember the neutrophils, it was red and blue, but here it's just red. The basophils, these are the smallest overall concentration relative to the others. The nucleus is going to be a deep purple with either 1 or 2 constructions in it, and the granules are going to look very dark purple, almost a black color to them, and they contain histamine. Histamine is an inflammatory chemical. It's going to act as a vasodilator. That means it's going to dilate your blood vessels, increase the diameter of them to increase the blood flow to them. Histamine is also going to act as an attractant. It attracts white blood cells to the inflamed sites. As we're going to find later, part of the inflammatory response is when you have an injury. There's the inflammatory response, and part of that whole response is to attract other white blood cells to the area of injury to attack whatever foreign substance there and prevent an infection from occurring, prevent any foreign substance from penetrating even deeper into the body. So the basophils are going to be involved with that, and release of the histamine triggers the inflammatory response, and that in turn gets more of the other white blood cells kind of come to the site. I need your help. And they are very similar to what's known. So this is what it looks like. You can kind of see its bilode in the very dark purple, almost black granules. And then remember we have the two agranulocytes. There's two different types of these, the lymphocytes and the monocytes. Both of them obviously are going to have nucleus in it. They will not have the granules in the background of them. The lymphocytes are the second most numerous of the white blood cells. They account for about 25%. So they're going to have very large, dark purple circular nucleus. It's going to comprise most of the cell. These will be found mostly in lymphoid tissue, like in your lymph nodes and your spleen. There are some that will be circulating in the blood. These are involved with your immunity. We will spend another whole chapter where we will talk about your immune system. But the lymphocytes will differentiate into either T cells that will mature in the thymus, and these T cells will play a huge role against virus infections and also be helping to protect you against tumor cells. The B lymphocytes, also known as B cells, these also play a role in immunity, but these are going to give rise to what are known as plasma cells, which in turn produce your antibodies against whatever that foreign substance was. So this is what the lymphocyte looks like. As you can see, it's large in size compared to the red blood cells. The nucleus, darker blue, is comprising most of the cell. Just so you know, those little tiny darker blue structures in between the red blood cells there, those are the platelets. And then your monocytes, these are the largest of the leukocytes, about 3 to 8% of all the white blood cells. They tend to kind of have either a kidney or a U-shaped nucleus. They will actually leave circulation when they enter the tissues. They differentiate and become macrophages, which are highly phagocytic. They play a large role in helping to protect you against viral infections, bacterial infections, chronic infections. And they're going to play a role in helping to stimulate your entire the lymphocytes that we previously talked about. They play a role with your whole immune system. So here's the monocyte. As you can see, the nucleus is not circular. It's kind of a U or kidney shaped. So once again, your 5 different leukocytes: neutrophils, eosinophils, basophils, lymphocytes, and monocytes. And so if you do a differential blood count, you distinguish between these 5 specific types. You don't give just a set number of leukocytes. You can distinguish between these 5 different types, and that sometimes can give you a clue. You know what the normal percentages should be for each of the 5. And so if one of them is much higher than normal, that might give you a little bit of a clue of, oh, is this a bacterial infection that the patient is suffering from, or maybe it's just an allergy. Leukopoiesis, the production of white blood cells, is going to be stimulated by different chemical messages that are coming from the red bone marrow and mature white blood cells. You have interleukins, you have colony stimulating factors. All leukocytes are going to originate from hemocystoblast stem cells, and then it's going to branch into 2 pathways. Your lymphoid stem cells are going to produce the lymphocytes, and the myeloid stem cells produce all of your other. So with the granulocyte production, you have the myeloblasts. They arise from that myeloid stem cells. You get the pro-melanocytes, melanocytes, band cells, and then finally your mature granulocyte. The agranulocytes, the monocytes derive from the myeloid line, and then the lymphocytes, they're going to be derived, as I said, from the lymphoid line. The T lymphocyte precursors are going to mature in the thymus. The B lymphocyte precursors will mature in the bone marrow. And this table does show a breakdown of starting with the stem cells. Which way does it go from that hematopoietic stem cell? Most of them will become myeloid stem cells, and from there it becomes that committed step of forming either the eosinophils, basophils, neutrophils, monocytes, versus the lymphoid, which is going to eventually become T cells or B cells. From a clinical aspect, many of the hematopoietic hormones are going to be used clinically. They can help stimulate bone marrow of cancer patients who have received chemotherapy or receiving stem cell transplants to try to increase the production, stimulate production, and also they can be used to increase to try to increase immune responses of patients who are immunocompromised. Leukocyte disorders, abnormally low white blood cell count is leukopenia. It can be drug-induced, oftentimes by anti-cancer drugs, because the white blood cells play a role with the immune system. That is why oftentimes individuals who are going through cancer treatments, some of these anti-cancer drugs do result in a low white blood count, and so then that individual's immune system is compromised, and they must be very careful on their exposure to any type of foreign substance, be it viral, bacterial, etc., because they're not dealing with 100% efficiency of their immune system. You've got to treat the cancer, though. Overproduction of abnormal white blood cells ends up with leukemias and infectious mononucleosis leukemias. It's usually cancer that's producing too many of your white blood cells that are abnormal. It can depend on which specific type of leukemia, which type of cells. Is it lymphocytic or is it myeloid that they derive from? Acute leukemia derives from the stem cells. It primarily affects children. Chronic or slow advancing leukemia is more prevalent in older people. So there's various types of leukemia. It just depends on specific cells and when it starts. Without treatment, leukemias are going to end up being fatal because you have all these immature white blood cells that are non-functional, and they start they're being released into the blood, they're flooding that bloodstream. Cancer cells can fill the red bone marrow, crowding out other cell lines. You end up with anemia. And so, like I say, this affecting the immune system, you end up with all these secondary infections. What's the treatment? Well, anti-leukemic drugs, irradiation, or stem cell transplant. Infectious mononucleosis, very highly contagious. It is viral disease. It's usually seen in young adults. It's caused by the Epstein-Barr virus. Usually what happens is you end up with very high numbers of agranulocytes. Oftentimes the lymphocytes become enlarged. Symptoms, very tired, achy, usually a very chronic, so long-lasting sore throat, low fever. It will run its course with rest in about 4 to 6 weeks. Platelets, So we talked about the erythrocytes, the leukocytes, and now the platelets. Platelets are fragments of what are known as megakaryocytes, and that is broken down. They contain several chemicals that are involved with the clotting process. Their function is to form a temporary platelet plug that will help seal any type of break or laceration in blood vessels until it can heal. Circulating platelets are kept inactive because you want to be able to control the plug when the clot is formed. So platelet formation is regulated by thrombopoietin. It's mitosis. What occurs, but there's no cytokinesis. So you end up with a very large cell with multi-lobe nucleus, but it never goes through that cytokinesis, which is the division of the cytoplasm. Pieces of it basically will break off, forming the platelets. Platelets will age very quickly. They degenerate in about 10 days, so they don't hang around very long. So here you have the stem cell. You're forming the larger stage 1, stage 2 to 3 is a megakaryocyte, and then finally in stage 4, you can see you have the little projections that are breaking off, the little pieces, and that's what the platelets are. This table is showing a summary of the 3 different types of formed elements. The erythrocyte, which is the red blood cell, it's telling you, obviously, a description, a picture of it, but it also tells you, under normal conditions, about how many cells per microliter of blood, the development, the lifespan, the function of it. So you've got the erythrocytes, you have the leukocytes, and it's divided into the 5 different types. Continued over here, and then finally the platelets. Hemostasis is a series of reactions that, for survival, basically, is to help stop bleeding. If something has happened and you're bleeding, you need to stop it so you don't have excessive loss of blood, which is going to decrease blood volume, which obviously is going to have detrimental effects for you. So the series of steps, it's going to require clotting factors. It's going to require substances being released by the platelets and also by the individual tissues. There are 3 major steps involved. Step 1 is known as vascular spasm. Step 2 is platelet plug formation. And step 3 is coagulation, which is just a fancy way of saying blood clotting. So step 1, vascular spasm. You have that blood vessel, there's been some type of injury, and the first thing that's going to happen is vasoconstriction. You want to decrease the diameter of that blood vessel. What's going to happen here, vascular spasms are going to be triggered by the injury itself. In the walls of the blood vessel, there's smooth muscle, so there's injury to that vascular smooth muscle. There are going to be chemicals that are being released, and then some pain reflexes. It's more effective in smaller blood vessels. And the idea is if you decrease the diameter of the blood vessel, you're decreasing the amount of blood flow that's going through there until you basically under control. Step 2 is the platelet plug formation. The platelets are going to stick to the collagen fibers that normally are not exposed. The inner lining of the blood vessel is typically smooth, and you don't have these collagen fibers exposed. But when you've had a tear, a laceration, a damage, and now some type of a cut through, now those collagen fibers are exposed, and the platelets are going to stick to them. There are usually some chemicals that are released also by the cells along the inner lining of the blood vessels that normally prevent the platelets from sticking. But you've had this injury, and so the collagen fibers are exposed. Platelets can now stick to them. There's what's known as the von Willebrand factor, which helps to stabilize this platelet sticking to the collagen fibers and helping this new structure now. When platelets are activated, they start to swell. They become kind of spiked and sticky, and they're going to start releasing chemical messengers. ADP causes more platelets to stick and release their contents. Serotonin and thromboxane A2 enhance that vascular spasm, so you get even more platelets sticking. It's a positive feedback. So basically, you've got some platelets that stick. They release chemicals. That's going to cause more platelets to come in and stick, and they're going to release more chemicals, and more come in and stick, and more, and so you're forming these platelets all coming in and sticking to these fibers. That's what you want, because you don't want the blood being able to be continued to flow out the injured site. So the platelet plugs work well for small tears in the small vessels, but if you have a larger vessel, larger diameter vessel. Step 3 deals with coagulation or blood clotting. This is going to help to reinforce that platelet plug by adding fibrin threads. This will be effective or more effective with larger blood vessels that have a break or tear in them. The blood is going to, in this area, is going to be transformed from liquid to gel. There's a series of reactions, and these reactions use clotting factors, which are mostly proteins in the plasma, so they're plasma proteins. They're numbered from 1 to 13, and the way they're numbered, it's not in the order of use, but in the order of discovery. Vitamin K is necessary to help synthesize some of these factors. There's going to be 3 different phases of that will occur with it. So first you have vascular spasm. That smooth muscle contracts, causing constriction. You're decreasing the diameter sides, decreasing blood flow. Step 2 is platelet plug formation. That injured site exposes those collagen fibers, and that allows the platelets to start sticking there. The platelets release chemicals that then make nearby platelets sticky, and then they're going to come and stick there and release chemicals, and you form that platelet plug form across the site. And then coagulation. These fibrin threads, they form like a mesh over the site, trap some of the red blood cells in there that form that gel from the liquid to the gel matrix. So it's like a net or a mesh that's over the platelet plug, and that's now formed a clot. With the coagulation, phase 1, there's 2 pathways, either intrinsic or extrinsic. Some usually uses both. It's triggered by the damage to the tissue, and it involves a series of procoagulants. You're going to end up with a factor X that's going to form a complex with calcium and platelet factor 3 and factor 5 to form this prothrombin. Basically, both of these, I'd say, are going to end up working together. The extrinsic pathway is, but as you can see here, they're both going to end up with activating the prothrombin. In phase 2, the prothrombin, now that has been activated, is going to activate the enzyme. Phase 3 is where the thrombin is going to convert fibrinogen to fibrin. So it's a cascade process that has to occur in this order. The fibrin is going to help to form that net to enclose the gel and form that trap, if you will, form that clot. Anticoagulants are factors that normally are in the blood to inhibit the coagulation from occurring, because obviously you want coagulation or blood clotting only to form at the site of an injury. You don't want it occurring elsewhere in the system. So this just shows once again the steps. And this is kind of a really neat picture showing a scanning electron micrograph, or SEM, of, as you can see, the erythrocytes that are trapped in that fibrin mesh. So you can see how it's holding it all together. And the blood clotting factors, as I said, there's 13 of them, and they're all listed here in order. And like I said, they're numbered according to discovery, not in the order that they are used. So the clot has to be stabilized, and then it needs to be removed once the damaged area has been repaired. So clot retraction involves actinomycin and the platelets to contract within 30 to 60 minutes. It's going to kind of pull on those fibrin strands, squeezing the serum from the clot. The serum is plasma minus the clotting proteins. It's going to help draw the edges of the blood vessel together. So those cut edges, bring them together. So the healing process starts right away. The platelet growth factor is released by the platelets that stimulates division of smooth muscle cells and fibroblasts to help rebuild that wall of the blood vessel. The epithelial lining of it will be restored because of the stimulation of the epithelial. Fibrinolysis is where the clots can be removed after the repair has occurred. Usually begins within a couple of days and will continue until the clot is dissolved. The plasma protein that has been embedded within the clot is going to be converted to plasmin, which is a digestion enzyme. So there's going to be a couple of factors involving controlling the size of the clot. You want to very quickly remove and then dilute those clotting factors so it doesn't continue to clot and form a very large clot. And you want to inactivate those clotting factors that were originally activated. It's like you need to stop, inhibit, turn them off. The other thing you want to keep in mind is, in addition to preventing the clot from getting too large, because if it gets too large, it's going to obstruct the blood flow in that area of the bloodstream. You also do not want it to escape and move further down the circulatory system. So antithrombin 3 is going to inactivate any of the unbound thrombin that possibly went downstream. Heparin, which is in basophils and mast cells, that also will inhibit thrombin. So they will also be involved with that. Smooth epithelial of the blood vessels prevents platelets from sticking to it under normal conditions. It is only that they will stick when those collagen fibers are exposed. So they will secrete certain substances that will also, in addition to the smooth surface, help prevent or inhibit the platelet adhesion. Vitamin E also, when it reacts with oxygen, acts as an anticoagulant. All these are going to work together to help prevent the clot formation. Two major types of disorders that obviously are going to play a role in hemostasis. Thromboembolic disorders basically result when you have an undesirable clot formation. You're forming a clot when you don't want to. And then you have the reverse, which are bleeding disorders, which are abnormalities that prevent clot formation when you need them. And some people have variations of thrombus is a clot that has developed and it persists in an unbroken blood vessel. And like I say, it may end up blocking circulation, leading to tissue death. And embolism is when you have an embolus, which is a free-floating clot in the bloodstream, and it has now moved and it blocks or obstructs the vessel. So a pulmonary embolism is when you have obstruction, you have a clot basically in the lungs. Cerebral embolism is when it's in the brain. There are different risk factors, like inflammation, if the blood flow is slowed down, because oftentimes that's due to being immobile. Those can increase your risk factors for forming these clots. Anticoagulant drugs are used to help to prevent clotting. Aspirin is an anticoagulant. It's one of the reasons why if you're going to have any type of surgery, they will usually ask you if you normally take aspirin to not take aspirin within a certain time period prior to surgery, because it is an anticoagulant. They don't want excessive bleeding during the surgery. Heparin is an anticoagulant. Coumadin, as well as dapagliflozin. Different bleeding disorders. There are different types of bleeding disorders. Some of them are due to when you have not enough platelets, so a decreased number of platelets circulating. Obviously, if you don't have enough platelets and you have an injury, then it can't form the clot, which is going to lead to excessive bleeding then. Some of these are due to destruction of the red bone marrow. What would be the treatment? Well, you could get a transfusion of concentrated platelets. Sometimes bleeding disorders may be due to impaired liver function, so you're not able to produce enough of the clotting factors. They may be involved with a vitamin K deficiency. Could be due to hepatitis. Could be due to cirrhosis of the liver. So that the liver disease ends up having another problem in that you're not producing enough of the clotting factors. So if you have liver disease, another problem there is the liver produces bile. And if you have a type of liver disease that decreases the bile production, bile is needed to absorb fat and vitamin K. Hemophilia is another type of bleeding disorder. It is genetic. There are different types of hemophilia A, B, or C. It has to do with which of the clotting factors is deficient, whether the most common one is clotting factor 8, which is hemophilia A. What happens here is because the clotting factors are used in a certain order, not, as we've said, not in the numerical order, but all of them will be used. One activates another, which activates another. And if you're missing one of those, then you can't complete the process. And so a person ends up bleeding, especially in joint cavities. Literally could lead to death from just what most of us would consider a minor injury. The treatment for that is injection of these clotting factors. Disseminated intravascular coagulation, or DIC, is where you have both widespread clotting and severe bleeding. You're having both. So you tend to have widespread clotting that occurs in intact blood vessels that have not been damaged. That's going to block blood flow. You may also have severe bleeding because residual blood is not able to clot because the clotting factors have all been depleted in forming the blood clot that wasn't necessary. This is seen in septicemia, sometimes with incompatible blood transfusions. With blood transfusions, cardiovascular system minimizes effects of blood loss. When there's damage, is going to reduce the volume that's traveling through a damaged blood vessel, and it's going to increase the amount of red blood cell production. That's the way the body tries to compensate for blood loss. But it can only do so much. If you lose between 15 and 30% of your blood, you're going to look really pale. You're going to feel really weak. You're going to know it. If you lose more than 30%, usually you cannot survive that. That's going to usually send you into shock. It will It will end up killing you. Whole blood transfusions typically are only used when the blood loss is very fast and it's a large amount. Usually you're just going to be transfusing with plasma or with red blood cells and basically they can separate out the plasma and the red blood cells, so all you're getting are the white blood cells, I'm sorry. They centrifuge, you get the plasma and white blood cells out, and then you just get the red blood cells if there's time to do that. So when you donate blood, they will, once they've taken your pint of blood, the blood bank's going to separate out the red blood cells. The shelf life is only about 35 days, so that's why there's always a need to replenish that. You have to run tests. You have to do blood typing to determine what is the blood type of the blood that was donated so that you can determine who can receive it. If you do a blood transfusion and you do not match the blood correctly, it can be fatal. So when we look at the human blood types, the red blood cell membranes, they have a lot of different markers on them that we refer to as antigens. And then we're going to use this for the blood typing. If you receive the wrong blood type, you're receiving the red, when you get blood transfusion, you're usually getting the red blood cell that has these antigens, these markers on them. So if, say, I were to receive a blood transfusion, my body may see those antigens as a foreign substance and attack and destroy them. That's what your immune response normally does. That's what it's supposed to do as a protective thing. However, in this case, so what type of antigens do you have on those red blood cells? There are a lot. There's over 30 of them. And usually you run tests and you're just testing for either yes or no. Either it's there or it's not. And that's how we identify you into the different blood types. Now, some of these are very weak. Some of them are known. There's an M&S, there's a Duffy, a Kell, a Lewis, a Lutheran. There's, like I say, over 30 of these. Most of these you do not test for if you just need a simple blood transfusion. If you are having transplant surgery, then yes, you want those 30 to match as closely as possible. If you're in a situation where, for whatever reason, you have received a lot of blood transfusions over the years, they're going to want to match them up as close as possible. But under normal conditions, they will only use what we call the major antigens and test for that. And that's where we get the ABO and the RH blood groups. Those are the antigens, so they look at those. So for the ABO blood group, you're looking to see whether you have these antigens, these markers, A and B, on the surface of the red blood cell. If you have type A blood, you only have the A marker or antigen on. If you have type B blood, you only have the B. If you're type AB blood, they're equally present, so you have both the A and the B antigen on. If you are type O blood, you don't have either one. Now, the blood in the plasma, you have certain antibodies. You could have anti-A and you may have anti-B antibodies. Both of these are antibodies that are naturally in the plasma. Now, excuse me, these will respond or bind to those antigens that are on the surface of the red blood cell. The anti-A and anti-B antibodies, they will form in the blood about 2 months of age. They're there and then slowly increase. And you'll have the 4 months. Now this chart shows the ABO blood types and who can receive what and how different frequencies with different population groups, what we see. So we start at the top left. The first column on the left is the blood group. So there's 4 different types. You have AB, B, A, or O. As we just said, those antigens that are on the surface of the red blood cell for each of the blood types are listed that we just went over. The plasma antibodies that are in your plasma. If you are type AB blood, you don't have any. And then you can see a picture of what the red blood cell would look like with the A and the B markers on them. If you are type B blood, you would have the anti-A antibody. Now, what would that bind with? What will it combine with? Well, it can react and bind to the A marker. You don't have the A marker on the surface of your red blood cell, so you're fine. Type A blood, you have anti-B antibody. And type O, you have both anti-A and anti-B antibodies. You don't have any markers on the surface of your red blood cell, but you have those 2 antibodies in your plasma. So now you have to figure out who can receive what type of blood. And the thing to remember here is that remember, when you receive blood, you're just getting the red blood cell. So once again, if we start at the top, a person who is type AB blood, they do not, you look at the red blood cell that you would be receiving, and you look at the antibodies that you already have. So if you're type AB blood, you don't have any antibodies. So it doesn't matter what the red blood cell looks like. So you can receive all 4 types. You can get type A, type B, type O, and type AB. You are known as a universal recipient because you can receive all 4 types. If you are type B blood, you can get type B blood. You can also get type O blood. Why? Because look at the red blood cell of type O. There's nothing on its surface. There is nothing to react with your anti-A. Now, you cannot receive type A blood because it has a marker that will bind to your anti-A. You cannot receive type AB blood because there's a marker that would react with your anti-A antibody. If you are type A blood, you can receive type A and type O blood. If you are type O blood, you are known as a universal donor. You can only receive type O blood. Why? Because look at your antibodies. You have both anti-A and anti-B. The other 3 types of blood all have markers on their surface, and one of your antibodies is going to bind with them. So if you're a type O, you can only receive type O blood, but you can give your blood to any of the other types because you don't have markers on your red blood cells. So you are known as the universal donor. And then the last part of the chart on the right shows kind of a breakdown of the frequency within the U.S. population. We do, because blood type is determined genetically, you're going to have certain ethnic groups, a prevalence for certain blood types within them. The Rh blood group, there are different markers known as Rh factors. The most common ones, there's 52 of them, the most common ones are C, D, and E. When we talk about the Rh factor, usually what we're referring to is the D antigen. So sometimes you might see it listed as D. 85% of Americans, and actually 85% of individuals globally, are Rh positive, meaning that they do have this D antigen. Anti-Rh antibodies are not automatically made. They will only be made if an Rh negative person is exposed to Rh positive blood. That's the only time. The first exposure is not going to cause a problem. It is any second and subsequent exposure to Rh positive blood is where you will have a reaction, and that's where the problem comes in. So if a person, that 15% of the population that is Rh negative, if they've never had a blood transfusion, they've never been exposed to Rh positive blood, nothing's going to happen if they get it. But the first time they're exposed to it, it's like, ooh, this is something new here. What's this D antigen? And they will make anti-Rh antibodies. Think of it as anti-D antibodies against it. And so the next time, the second and any subsequent time they are exposed to it, you could potentially have this clotting reaction that can occur. When does this play a problem? If somebody is Rh negative, and the most common problem is when a mother is carrying an Rh positive fetus. It is known as hemolytic disease in the newborn. First pregnancy that a Rh negative mother is exposed to Rh positive blood is usually not going to be a problem in terms of the baby or the mom. However, the mother's going to be exposed to, normally there's no mixing of the blood between the mother and the developing baby. However, at childbirth, she is going to be exposed to the blood, and she will then start producing the anti-Rh antibodies. If that mixes with the Rh antigen, that Rh positive, it will clot. So what happens is that in a second pregnancy, the blood does not mix between the mom and the baby, but antibodies are small enough they can cross the placental barrier. And what happens is the mother's anti-Rh antibodies, they cross the placenta into the developing baby, and they destroy the red blood cells of the developing baby. Now, how are you going to treat this? Theoretically, the baby can be treated with transfusions prior to birth while she's still in utero, and then also after birth. Obviously, there's risk involved with that. The most common way of treating this is that normally during pregnancy, they're going to do a blood test very early on, and if it comes back that the mother is Rh negative, they will give her a shot. It's called Rogam. It contains anti-Rh that basically it ties up and prevents the mother from becoming sensitized. It kind of ties up and binds should there be any of the Rh positive cells there. They will usually give Rogam partway through the pregnancy. I believe usually it's around like week 28, and then at childbirth they will also give a second shot of this. And then they will monitor in any subsequent pregnancies. They know to monitor very, very closely. If it is not treated, if it is not dealt with on subsequent exposures, this clotting of the mother's antibodies with the developing babies can be fatal to the fetus. Transfusion reactions, this is only if you basically mess up and mismatch the blood. If you have the antibodies that will bind and start forming clotting, this clotting starts immediately, and once again, it can be fatal. The symptoms, usually you get a low blood pressure, rapid heart rate. I have known, actually, I knew someone, actually my mother-in-law, who was in the hospital. They started a blood transfusion, and immediately she turned to my father-in-law and said she was not feeling well, that something was wrong. She just felt something was off, and he could tell by looking at her that yes, something was wrong. He yelled for a nurse, and he had been a med tech during World War II. And so with his background, he immediately put two and two together that she was okay, started feeling funny as soon as they started the blood transfusion. So as he yelled for a nurse to come in, he jumped up. He did not wait for the nurse to get there, and he basically pulled the needle out that was administering the transfusion. And they said later that is probably what saved her life, because they went back and checked and realized, oops, they were giving the wrong blood type. Well, that is a major oops, and it can be fatal. Sometimes if people know that they are going to potentially need a blood transfusion, say if they know ahead of time they're having surgery, sometimes a patient can donate. They call it pre-donate. You donate your own blood, and that is stored. And so that way, if you need blood during surgery or whatever procedure, you're actually getting your own blood. Obviously, there's a timing issue that has to be there involved because the red blood cells are only going to be viable for about 35 days. It's usually how long they'll keep it. But that is, some places will offer that as an option. If the blood volume is too low, obviously you go into shock. You may not be able to recover from that. You need to replace that volume. Try to get that volume back up. Immediately, you can give saline solution. It has electrolytes in it to help mimic what that plasma electrolyte composition is. That would restore the volume. The problem is that does not restore the hemoglobin in the red blood cells that are carrying the oxygen. So you're not restoring the oxygen carrying capacity. You're just restoring the volume. There's lots of different types of blood tests where you can get an idea of what a person's health is. Low hematocrit is going to be seen with anemia. You can do blood glucose checks for diabetes. You can look at the leukocytes to determine if there's an infection. And if you do a differential count, you can determine is it viral, bacterial, parasitic worm versus allergies. You can do a microscopic examination and look at the size of shape of red blood cells, see if there's abnormalities in size, shape, color. You can do platelet counts to get an idea of hemostasis. You can do a comprehensive medical plan where you're looking at the chemicals that are in the blood. And that can give you indications in terms of kidney function and liver function. Complete blood counts, CBC, this is going to be looking at the formed elements, the hematocrit and the hemoglobin.